Good afternoon, everyone, and thank you for joining us again. Thank you for being with us for all those weeks. I even lost count. I think it's around 12 weeks, twice a week, all of you joining us every time. So today is the second last of our webinar. Today, the guest speaker is Prof. Ute. She's a pediatrician in Tshwane District Hospital, also a specialist in University of Pretoria. She is a head of clinical unit there in District Hospital. She's also a director of University of Pretoria Research Center for Maternal, Fetal, and Newborn and Child Health Care. She has PhD in child health, and out of many of her interests also include improving neonatal outcome at primary health. So we are really honored, Prof, for you to having you here in our rooms and in our homes and listening to you for the coming hour. We can't wait. We've been waiting for this opportunity for a very long time, and thank you for your time, Prof. Prof, I must just tell you, we have also our head of clinical unit from University of Limpopo, who is Dr. Hamis, as a pediatrician here locally, and pediatrics for the whole province, because it's a tertiary hospital, it's responsible for the whole province. And thank you, Dr. Hamis. And I know that Dr. Mbulelo Chamisiwe is going to be also joining us, one of our pediatricians. So, Prof, without wasting time,
friendly introduction. Let me just find my slides. Great. So welcome everybody. It's the weird way of doing training these days. Sitting in front of a computer and I'm talking to my pot plant here and imagining a whole lot of people listening. And so that's the bad of this new way of training. But the good way of this new way of training is that we can actually do this. I'm sitting in Pretoria, and many of you would be in Limpopo, I'm sure. And we are here, and we can actually spend the afternoon together, and we can think about a topic together. And actually, I can show you my presentation, and we can have an interaction around it. So this is really fantastic. I must say the topic I was given is not so easy for an online training because obviously neonatal resuscitation is actually a practical skill, and that's not so easy to demonstrate over the distance that we unfortunately are at. But I've put together a slideshow for us to, and it's as practical as possible with such a topic. So just as an introduction, I think neonatal resuscitation is both the background knowledge that one needs to have, as well as obviously the clinical and practical practice of this. So the practice, we can't do this afternoon. This is going to be your homework to do this when we are, in the next few days. But I think obviously it's a good idea to always ground the practice into good knowledge. Yes, so neonatal resuscitation is an absolute crucial skill. There should not be a health worker who cannot do neonatal resuscitation. And I've called this step-by-step towards saving babies. I mean, we are all in this business of saving lives. This afternoon we're going to talk about saving babies. And as per introduction, I'm the pediatrician in the Tshwane district specialist team. Okay, so here's my little quiz question to start off. To get us thinking into this, do you suffer from neonatitis? Now, what on earth is neonatitis? So here's the definition. It's the irrational fear of healthcare workers to care for neonates. So guess what? This is not a real word. This comes from, it doesn't exist in any dictionary. It comes from my own dictionary. And it is clearly, it actually doesn't exist, this word. But the concept I have seen so many times in clinical practice. People who are health workers and who look after real patients every day, but just don't give them a baby. They are very scared that these little things are very fragile and that they can do something wrong. The problem is, if we have neonatitis, we actually have a real good chance of harming babies, because the worst thing we can do is stand next to a baby and say, oh, I don't know what to do, so I don't do anything. So this is really something that we need to help people to overcome their fear of working with neonates. Think around what are the causes of neonatal deaths in South Africa, and that depends on whether you're born small or whether you're born normal size. And so the small babies, the main cause of death is prematurity, and the big babies who are born above 2.5 kilos, the main cause of death is asphyxia. And then there's the looming infection risk that is always around. That is the third big cause of neonatal deaths in our country. So today's presentation is going to be mainly around bigger babies who are born asphyxiated and who require neonatal resuscitation. Obviously, some prematures also need neonatal resuscitation, and there are a few special things with them as well. But today is really about the big baby who is born and who then doesn't breathe as we expect him or her to breathe, and then actually has a risk of dying if we don't do this correctly. So as a country, we have got a neonatal strategy, and these are the focus areas for district implementation. And it's 8 high impact factors that have been put together to say, if we do these well, we will save a lot of babies' lives. And just look at them. Neonatal resuscitation is right at the top of this list. But then there's immediate assessment and stimulation. There's exclusive breastfeeding, immediate thermal care, clean birthing areas, hand washing with soap, kangaroo mother care, and newborn in-facility care. And so it's really the last one, which is what usually people think around when they think about what we need to do if we need to improve neonatal outcomes. We need to build neonatal ICU. We need specialized staff to be actually able to look after very sick babies so that we can save their lives. So clearly we do need neonatal units. There's no question around that. And we also do need neonatal high cares and ICUs. But actually just look at this list. The high impact factors, the great majority of them are very low-tech, non-expensive things that we can do, and we should be doing at 100% in all of our facilities, MOUs, district hospital, regional hospital, and we would save a lot of lives if we get this right. And then there is the South African newborn care package. And actually, this comes from Limpopo, the LINK project, which then became this SANK project, which is really looking at recommended standard for essentials for newborn care. So you have really paved the way for our country to say, this is what we need to do if we're going to save babies' lives. And there, under the essential newborn care services, right at the top of that little list is the neonatal resuscitation at birth. We also need routine care, and then we need inpatient care for sick and small newborns, and that's where the hospital care comes in. But actually, we need routine care and the ability to resuscitate neonates at birth for all our babies that require it. So just a little background information, just reminding people why babies actually sometimes do need some help after birth in actually adjusting to the postnatal time period. And for me, this is now a fancy slide. It says physiology, and it tells us that the fetal circulation, there's a placenta there where the oxygenated blood now comes from. It goes via the ductus venosus into the inferior vena cava, and then into the right atrium. Then it's shunted in the middle of the heart. It's shunted through the foramen ovale into the left atrium, and then it's so we are also bypassing the lungs, because the lungs are not necessary in utero, and there's the ductus arteriosus. So all these fancy names, and people try and remember how all of this works, but this is actually the miracle of life that happens after birth. That we have the fetal circulation that then changes over to the adult circulation within a few seconds, a few minutes. And this is, and that it actually happens normally in most of our babies after birth is an absolute miracle. So why this is so important is because if we see an adult in a casualty department who is hypoxic and who's bradycardic, chances are he or she had a heart attack or something like that. And so our intervention for an adult who requires resuscitation is very different to a newborn who doesn't have a cardiac arrest because of a cardiac problem. The newborn has got a physiological adaptation that he needs to go through from the fetal circulation to the adult circulation. So what happens after birth then is the baby loses the placenta as its oxygen source. It needs to take his first breath, and then and this first breath is because of the exposure to cold and the tactile stimulation that the baby now is exposed to. This means the airways and the alveoli open up, and the baby needs to then establish normal respiration. The gas exchange then starts taking place at the level of the alveoli. The fluid that's usually in the alveoli is then absorbed and replaced by air. There's vasodilatation of the pulmonary circulation, the establishment of the pulmonary blood flow, and there's the alveolar perfusion, and blood gas exchange starts at the level of the lung, and the oxygen is being absorbed. And again, that this happens within a very short period of time, really, literally within the few minutes after birth, is an absolute miracle. And that it happens normally in about 90% of babies without any really additional help is really amazing. And then what happens is that the lung vessels, the blood vessels relax, and there's increased systemic blood flow, which means that there's increased pulmonary blood flow, and the flow through the ductus arteriosus reduces, and we have decreased mixing of oxygenated and deoxygenated blood, and the circulation changes over to the neonatal circulation. So that's sort of on a anatomical level. And then on a physiological level, this was the last slide, just sort of the basic science slide as an introduction, which tells us why we sometimes actually need to intervene in babies. So what what we see in babies on a physiological level is that we have this period after birth where the babies have rapid breathing, and then they can have primary apnea, and in that phase the heart rate also decreases. After the primary apnea, they would then have a period where they can have irregular gasping if the primary apnea is not turned around. And so from the irregular gasping period, you would then have the secondary apnea phase. And that is when we are really in trouble in terms of neonatal resuscitation. So usually what we see is babies with primary apnea. But if we get to the phase of secondary apnea, that is when the clinical intervention is really necessary. And that's also the phase where the blood pressure falls and the baby's circulation really is in trouble. So if the baby does not begin breathing immediately after you've stimulated him, he or she is likely to actually be in the secondary apnea phase and will require positive pressure ventilation to actually reverse this situation. Yeah, so that is the background of why what needs to happen and why things sometimes go wrong, and what we need is practical help for health workers on the ground to say, okay, this is what I need to look out for, this is what I need to do. This is like the pilots that do simulation training, because pilots, if they fly airplanes, they don't have the real life experiences of actually practicing what to do in a crash situation. Because if they ever get into that situation, the chances are they're not going to survive it. So they are not going to practice it in real life. So pilots do a lot of simulation training in flight simulators, where they actually practice how to keep calm and what are the next steps that they need to do when they actually get into this absolute emergency situation. And that is what Help Babies Breathe as a program helps us as health workers. It is an education program in neonatal resuscitation for birth attendants, so that we know what to do in these stressful situations and that we don't get ourselves all worked up because of the adrenaline that's pumping through our veins. The other really important concept of the Help Babies Breathe project is the golden minute. Okay, and we'll come back to that. The golden minute is absolutely crucial. That is where we need to do all the good things in order to help the baby survive. So within this golden minute, the baby needs to either breathe spontaneously in that first minute, or we need to help the baby to breathe within that golden minute. Okay, so that's the choice we have. Either the baby gets to establishing breathing on its own, or we need to help the baby in that first minute. And then clear the airway and stimulate the baby. And if that doesn't address the issues, the non-breathing or the irregular breathing, then we need to start bag and mask ventilation within that first minute. This also means that we cannot waste time running around looking for the ambu bag. Everything needs to be ready because we only have 1 minute to get this right. So people are scared of babies at birth. I know that. I've seen that so many times, and this is a very human thing. So you don't need to be afraid of this fear factor. Okay, so if we think around most deliveries that we have attended, or that so the majority of babies actually just require immediate assessment and routine newborn care. Then there's about 5 to 10% of babies that require stimulation and clearing of the airway at birth to help them breathe. So, which actually tells us that the great majority of babies don't need additional help. So that already helps us with the fear factor. Okay. Then we have this group of babies who require some stimulation. Then we have a smaller group of babies that require basic resuscitation, which is bag and mask ventilation. And the group that everybody is always so extremely scared of, the babies that need advanced resuscitation, that need chest compression, that require drug medications, it's less than 1%, and it's actually a very small group of babies. So by learning some basic skills that everybody who puts foot in a labor ward or in a casualties can really easily learn, we can save the great majority of babies who do have adaptation issues after birth. Okay, so if you just get this into your own mind to say, I don't need to be scared that every baby will complicate on me, then already we have won a great deal. So Help Babies Breathe is about the first minutes after birth that are critical to reduce neonatal mortality. It is a simulation-based neonatal resuscitation program for low-resource settings, and it focuses on the initial steps of resuscitation, but it also includes steps like the immediate drying of the baby, providing warmth and additional stimulation to breathe, followed by bag and mask ventilation if needed, and then all of this within the first 60 seconds of birth. So really centered around this golden minute. The immediate care of the newborn, if we think around what are the aims around this, so the aims are to know how to prepare for immediate care of the newborn and resuscitation, so that's the preparation. To recognize the life-threatening illness in the newborn, so if we get into that red area where the baby is really in trouble, that we actually recognize this early. To practice the techniques of resuscitation and treatment of life-threatening illness, and to achieve competence in those techniques. So it's about knowledge, but it is also about practicing competence. So HBB is not just about resuscitation, as I've already said. It includes key strategies that improve neonatal outcomes. This includes good communication with the mother, obviously, which we often forget. It's so logical, but we often forget to do that. And also good communication with other health workers. It's around preparedness, around hand washing, drying the baby and keeping baby warm, immediate skin-to-skin contact, delayed cord clamping, and breastfeeding. And the thing is, if we do these things right, we actually avoid problems. So a baby that is left to become cold might actually just complicate on us. Whereas if we had just kept him warm, this baby may have just been absolutely fine at the mother's bedside. So the Help Babies Breathe action plan is color coded, and there are so you can see the poster that is attached, is linked to the HBB program, is color coded. So the top part is, which is you can't see here very well, is actually gray, which is the preparation phase. Then there's green, which is routine care. There is yellow, which is the golden minute, which you can also see on this graphical depiction. And then there's the red area where you need to do advanced intervention. And it hinges around evaluation, decision, and action. So, and evaluation, there are 3 questions you need to keep on asking yourself when you assess the baby after birth. Is the baby crying? Is the first question. Is the baby breathing? Is the second question. And what is the heart rate of the baby? So these are the 3 things you need to embed in your mind: crying, breathing, heart rate. Because those are the steps that take you, decision steps that then take you through the algorithm so that you know what the required action is. So we're going to go through these things in a very logical way, and that's again how this program is set up, so that you can ask yourself a question, and then depending on the answer to that question in that clinical scenario, you actually know what the action is that you need to do. Okay, so just coming back, starting off with the gray phase of the HBB, which is the preparation for immediate care. Okay, and this is really so important, and we would reduce our stress levels tremendously if we would put more time into the preparation phase. So the preparation phase is around getting an assistant, having a communication plan, knowing if you get yourself into trouble because you have a really sick baby, that is, this is the person who's going to help you, and this is the communication plan you have. Then it's the preparation for the area of delivery and the equipment that you need for immediate care. So this you need for every single delivery. So you need warmth, a heater, you need to have the windows closed, have towels ready, have the area for delivery right. Then prepare an area for resuscitation. Make sure the area is available. It is not, there are not a whole lot of patient files lying on top of your resuscitation area. Make sure that you have a radiant warmer, that everything is on, that it's working, that the oxygen is there, that the bag and mask is there, everything that you need. And there's the preparation for equipment for resuscitation. And check this before the baby is born. I mean, that is really, you reduce your own adrenaline levels by actually doing this. Then you need a clock in order to time that. How else are we going to time our golden minute? And hand hygiene has always been important. And now in the era of COVID, I think we've all learned a new important lesson around hygiene in our health facilities. The next thing is, so prepare your area, but then also anticipate the risk. And the risk factors can be maternal related, can be pregnancy related, and can be labor related. And if you are at a lower level of care and you have identified risk factors, make sure that you arrange transfer for the high-risk patient. Write the problem lists, identify problems, write problem lists, and arrange transfer to the correct level of care. If we do this consistently, we already avoid a lot of problems at our health facilities. So these are the maternal, they are just some of the maternal related risk factors. These are nothing fancy, but just remembering that the risk factor, so this is looking at the mother's health and her demographics and understanding whether there are risk factors there. Then there are risk factors linked to the pregnancy itself, which are listed here, which are, again, this is not rocket science, this is not difficult to do, but it is important for us to identify these pregnancy-related risk factors and ask ourselves, is this mother at the right level of care? And am I anticipating problems? Because if I am anticipating problems in the delivery, then I should make sure that the necessary help is there, that the necessary expertise is there. And then there are labor-related risk factors, which are some of them are listed here. And again, this is what the bread and butter of labor wards management, but knowing that we should identify these early and we should call for help early. Good. So that was the preparation phase, and that's the gray section in the HPB program. Then we get to the immediate care after birth, and you will see that my text is green here because that's the coloring in HPB. So the immediate care is about drying the baby thoroughly and asking yourself, is this baby crying? And if the answer is yes, then we keep the baby warm. We ensure that the baby is breathing, and then we cut the cord after 1 to 3 minutes. This is the delayed cord clamping that we have started doing quite a while back now. This is to reduce the risk of anemia in the baby. And then we take the baby to the mom for breastfeeding and kangaroo mother care, and we just keep on checking that the baby is actually breathing well. So the first question, is the baby crying? And if the answer is yes, we can certainly staying in this green area. If we are asking ourselves, is the baby crying? And the answer is no, then we are still green here, but we are starting to get ourselves a bit worried. So here we just say, okay, we need to position the head, look whether we need to suction the baby if there are secretions, and we need to stimulate the baby. And we need to ask ourselves then our next question, which is the baby breathing well and regularly? And if the answer to this question is yes, so the baby might not be crying very loudly, but is breathing well and regularly, then we are still green. We keep the baby warm, we cut the cord, and we take the baby to the mom for breastfeeding and kangaroo mother care. So these are the 90% of babies that really are able to do this transition after birth pretty much on their own with really minimal help from our side. So, but just the reminder to all of us that we need to make sure that we need to check breathing while we are maintaining the airway. And we do this by looking, listening, and feeling, and really making sure that the baby is breathing well. Yeah, so just a reminder that the breathing normally means also that there's no indrawing or retraction or grunting. And if this is the case, we will give the baby to the mother and encourage kangaroo mother care and keep under observation. Good. So now you can see that the color of the text has changed to orange. So what if the baby is not crying and we're positioning the head and suctioning if there are secretions and we're stimulating the baby? And then our next question, remember, is to ask ourselves, is the baby breathing well? And if the answer is no to this question, now we know, okay, we need to call for help, we need to cut the cord, and we need to start bag mask ventilation. And you can see that this is actually, we shouldn't be taking a very long time to get to this step where we actually say we need to do bag mask ventilation, because remember what we need to do is we need to help the baby to expand his lungs so that his circulation can change over from the fetal circulation to the neonatal circulation. We need to ensure that the airway is maintained, head in neutral position. We may use a towel under the shoulders of the baby, head tilt, chin lift, and only suction very gently if necessary. So the open airway, the position that we need to aim for is the sniffing air position, which is the top picture there. The incorrect positions are both hyperextension and flexion. So we need to be aware that we can go overboard in both directions in terms of hyperextension and in terms of flexion. So the correct airway, the correct position is absolutely crucial so that the baby's airway is well open. In terms of suctioning, we do not suction routinely. Previously, or many years ago, we were suctioning all babies very vigorously, but that is really not done anymore. And this is because it is potentially harmful. Overzealous suctioning can cause laryngospasm, bradycardia, and minor abrasions, and it can really cause much more harm than good in many of the babies. If you do need to suction, remember that to suction the mouth before the nose. So you can remember that M comes before N, so mouth before nose. You can also think 1 comes before 2, so the mouth is like one little hole to suction, whereas the nose has got 2 holes. So if you start with the 1 and then go to the 2, but that is the how we need to do the suctioning. And then there's the rule of 5. So the suction catheter must be passed to a depth of no more than 5 centimeters and suction for 5 seconds. Okay, so that's if we needed to do suction. If we now we are at helping the baby to breathe. So now we need a bag and mask to do that. We place the mask that's obviously attached to the ambu bag to cover the mouth, the chin, and the nose. We should use a neonatal ambu bag. Don't use an adult one because you can you can cause serious barotrauma to a baby, and the PEEP valve needs to be functional, otherwise you can cause severe barotrauma to the baby. Use room air for resuscitation. This was also changed from many years ago. So especially in term babies, we would use room air for initial resuscitation. This also makes it much easier for you. And this is because what the babies really need, the great majority of babies, is the expansion of the lungs. It is not so much the oxygenation. And hyperoxygenation can actually be harmful for babies. We ventilate with bag and mask for 30 to 40 breaths per minute for about 30 seconds, and we check that the chest actually rises. So this might not rise very well into the first few breaths, remembering that there's fluid in the lungs initially, but you do need to check that after the first few breaths that the chest actually rises well. So for 30 seconds we do this, then we reassess the respiration and breathing. If breathing well, we can stop the bag mask ventilation and monitor the child. So in many cases, all you need is those 30 seconds of bag mask ventilation, really just to help the baby adjust to the neonatal circulation and breathing. But you obviously need to see whether this is successful, and if the baby is still not breathing or breathing irregular, now we need to check for the heart rate. So this is our third question. So the first question was crying, yes, no. Second question was breathing, yes, no. And now the third question is heart rate. What is the heart rate? And the number to look out for there is 100 beats per minute. A heart rate of more than 100 is a sign of successful oxygenation in the baby. So just before we move on, just a reminder that with bag mask ventilation, if you use the bag with no additional oxygen, you would be giving 21% oxygen. If you add oxygen to that, to the oxygen pipe, you attach the oxygen pipe, you get to about 40%. And if you add a reservoir bag, then that oxygen saturation, or the FiO2 that you are providing to the baby goes even much higher. That depends on a few things, for instance, the flow of the oxygen that you are giving. But that is the increment of how you increase the oxygen that you give to the baby. Effective bag mask ventilation, you can see by improved heart rate, effective chest expansion, and improvement in the baby's color. Common causes of ineffective ventilation are poor position, airway obstruction, poor mask application, or inappropriate or a faulty bag that you are using. And while you're doing bag mask ventilation, check the chest rise. Use your eyes and look at the chest movement. And look, if the chest is not moving, look at the possible causes for that. Is the seal of the mask adequate? Is there any obstruction? Do we need to ventilate more firmly? Knowing that usually we just actually need to use the thumb and 2 fingers and a small neonatal bag to do the neonatal resuscitation. Do we need to intubate this baby if the chest rise, if there's really seems to be another problem that is causing the ineffective ventilation? Is there an underlying abnormality like a nasal choanal atresia or something else? and is there gastric distension that actually is pushing on the lungs. So this is like your little numeric to think around when the chest is not rising. Okay, so now we are at circulation. Remember, the third question is, what is the heart rate of the baby? So the best way of assessing the heart rate is to use the stethoscope, count for 6 seconds, and because then you can multiply what you have counted by 10 and you're not wasting a lot of time. You can also palpate for the umbilical pulse, which if you can feel it, is also a very rapid and accurate way of assessing the heart rate of the baby. So if no heart rate or heart rate less than 60, now we are in deep red here, we now need to start giving chest compressions. And remembering that the most common reason for low heart rate is inadequate oxygenation. So you never give chest compressions without bag and mask ventilation, especially not in a newborn. Okay, so you can do there are 2 techniques to use. So it's either the thumb technique or the 2-finger technique. I'll show you another photo just now, or a depiction just now. The position for the chest compression is the sternum below the internipple line. The depth is 1/3 of the AP diameter of the baby, and the ratio is 3 compressions to 1 breath. Okay, so 3 to 1, that is what you need to remember. Once the heart rate is above 60, then you stop giving the chest compressions, but if you still need to continue with the bag mask ventilation, you still need to continue with that. So these are the techniques, either the hand encircling, around, so or the 2-finger technique that you can use in newborns. Good. And then a few words just about medications. Okay, so if you can choose only one medication to take along when you go to a neonatal resuscitation, you would choose to take adrenaline along, and you diluted 1 ml of adrenaline with 9 mils of normal saline to get a 1 in 10,000 dilution. And then you give 0.1 milliliter per kilogram of this diluted solution. So if the baby is 3 kilograms, you would give 0.3 milliliters of this diluted solution. If you have no intravenous access, you can also give adrenaline through the ET tube, and then it's the non-diluted solution, or it's 1 at 1,000, and you would also give 0.1 ml per kilogram of that. Sometimes we do get ourselves into a situation where we unfortunately need to think around considering stopping the resuscitation. And this is obviously there are no hard and fast rules, and we are always very scared of doing this, but there comes a time where we actually need to decide to stop resuscitation. And this is, so general guidelines for this would be if no heart rate from birth and up to 15 minutes of resuscitation and there's still no heart rate, or if there's no gasping or no breathing after 20 minutes of bag and mask ventilation, or gasping but no regular breathing after 30 minutes. And this is a decision that where you should call for help, and you should discuss it with a senior person. The most senior person that is around should help you with taking such a decision. So that is HPB, really helping people to move from step to step, remembering the questions of crying, breathing, and heart rate, and taking you through the decision steps then. So that is how this program is structured, but again, one actually does need to practice this, and we need to have HPB fully rolled out in all of our labor wards, and casualty staff should also be well trained on HPB. So all our health workers whoever have any chance of attending a birth need to be trained. So it's midwives, nurses, and doctors. The doctors also need to be trained in advanced resuscitation, but we really need to be aware that advanced resuscitation can be a disadvantage to the baby if the basics are not done correctly. If we jump into intubation while we should have actually first done proper bag mask ventilation, for instance, then we have a real potential of actually harming the baby. So the advanced resuscitation comes after the initial steps and not instead of them. Help Babies Breathe also has these posters that we can use for training, that we can put up at in our labor wards. This is, for instance, a poster on how to prepare for the birth, how to ventilate, and how to improve ventilation. But it is also a skills-based program. So, and this is because we need both knowledge and skills of practice to actually do this well. We can look at a lot of nice presentations on neonatal resuscitation. This is like driving on a bicycle. You can look at it 1,000 times. When you actually go on, if you sit on a bicycle the first time in your life, you're probably going to fall off. So it is the practice that actually makes it perfect. And then when we do the practicing, we should actually have different case scenarios that we practice. And this is, for instance, here tracking 6 different cases and practicing the different variations that this can happen. And then there's the neonatal simulator. So we should be, obviously we can't practice on real life babies. So we should be practicing this on dolls so that we are really feeling comfortable in doing this. There's also a very nice training video on neonatal resuscitation using the practice doll, which is available on the internet. So there are resources that we can use so that we can get ourselves more organized and familiar. And the other thing we need to remember, this is a stages of change, a model of how we implement any quality improvement in our health system. So initially we create awareness, then we commit to implement, then we prepare to implement, and then we implement. But the step that is really crucial is the integration into routine practice. And we need to do this. And then we need to sustain new practices, and we need to sustain the drills. It doesn't help just sending people once for neonatal training and then never doing drills within the clinical setting. So these two things really need to go hand in hand, and the drills need to be done regularly so that everybody who is on the floor in the labor ward feels comfortable using a bag and mask and knowing how to assess a baby and how to do bag mask ventilation on a baby. And then just lastly, a few other related topics to just round off this discussion. The one is just a slide on the APGAR score. We do this every day in labor wards, but we shouldn't have all our APGAR scores 9 out of 10 and 10 out of 10. Then we're clearly not doing them well. We need to take them seriously and assess and score the APGAR scores well so that they are actually helpful to us in our clinical practice. Then there is the issue around hypothermia. We should be really good at routine prevention of hypothermia, because a baby who gets cold after birth really gets ourselves and the baby into trouble, which we could have avoided. So we need to make sure that our environment is warm and that we give the baby to the mother to suckle as soon as possible, avoid early bathing, avoid damp clothes, those damp towels that, and those green sheets that we use after birth, if they're wet, they're really not going to hold the baby warm. We need to make sure that we wrap the baby in dry towels, and that really keeps them well. And once we have a baby who's hypothermic, we need to manage this immediately. We cannot let babies become cold. And then related to that is hypoglycemia. We need to look out for the clinical signs, which can be varied, and are listed there. Then routine prevention is really important. Early frequent small feeds, and if there's any sign of infection in the baby, we need to manage that, because that can also cause hypoglycemia. If we diagnose hypoglycemia, we shouldn't just leave it and document it in the file. We need to do something about this. So we need to feed the baby if preprandial and then recheck the glucose. And if the baby's NPO already fed, then we need to give glucose to the baby either intravenously or through the NG tube. And if a baby has convulsions and is hypoglycemic, then we also just need to remember that there is a differential diagnosis attached to this, and we need to assess this baby further. And just before I end off, I just brought along some information about NeoPuff and about intubation, so that we can round off this discussion and using these as sort of additional components that people should be aware of. So the NeoPuff infant resuscitator may be available in your hospital. And if yes, make sure that you use it instead of a bag and mask. If you have a neopath, this is certainly the better way of resuscitating the baby than using a bag and mask. So don't be afraid of this machine. It's actually very simple to use, and it has a lot of advantages. So the advantages are that it can provide CPAP and PEEP. You, as an operator, can set the PIP and the PEEP. It cannot deliver pressures above the set pressures if your gas flow is constant. And your PIP and your PEEP are displayed on the manometer. And the big advantage of this is that you can prevent barotrauma to the immature lungs. And this is really important for babies. We can really hurt their lungs by overzealous bag and mask ventilation. And the more preterm a baby is, the higher risk for barotrauma. This is not a very sophisticated piece of equipment that is hard to use. It is really easy to learn to use the neopath. What you need to be able to do is adjust the inspiratory pressure, to adjust the PEEP, which you do there at the valve. And then for inspiration, you just put your thumb onto the little hole. And for expiration, you just remove your thumb. And that is almost all you need to know on how to use this piece of apparatus. So close the T-piece for inspiration and release it for expiration. You count, breathe, 1, 2. So you breathe. So on breathe, you close with your thumb, and on 1, 2, you release. So that's how you can count for yourself to make sure that you get the rhythm right. So why is this a good piece of equipment? Except for the barotrauma, it's the effective PEEP that is important, because this is a little picture of your alveolar, and especially babies' alveolar initially are prone to collapsing. So if we use the PEEP, then the alveolar are kept open, as in the top picture there, and that helps the gas exchange in the baby. Okay, and then lastly, just a few words on tracheal intubation. So this falls more under advanced resuscitation. This is for non-vigorous baby who does not improve with chest compression and bag mask ventilation. In the resuscitation environment, we would usually prefer to do oral intubation instead of nasal intubation. So if you go into a neonatal ICU setting, you will see most babies are intubated through the nose. But in the resuscitation environment, oral intubation, especially of people who don't do this every day, is certainly easier and is the preferred option. So this is a skill that needs to be practiced. It's all about positioning the neonate, holding the laryngoscope, what to put into your dominant hand, what to use your non-dominant hand for, and then practicing on doing this. In terms of the laryngoscope for neonates, a straight blade is preferable to a curved blade. So this is what we should have available on our resuscitation trolleys. The ET tubes are sterile disposable tubes. They should have a uniform diameter and not tapered near the tip. We don't use inflatable cuffs in newborns. And then there is this marking for the vocal cord at the tip of the ET tube, which, as on the diagram, as you can see, you actually push through the marking through the vocal cords, and then you know that your ET tube is positioned nicely. This is the ET tube size and the level of insertion that you need to use for newborns. So for a small preterm baby under 1,000 grams, you would use a 2.5 size, whereas for a big full-term baby, you would use a 3.5 or even a 4. And then in between, you would use a 3 or a 3.5. There's the weight plus 6 centimeters that gives you an indication of the depth that you need to go to. And then, as I said, you look at the level of the marking. The positioning is what you need to, that is what one needs to practice. The really important thing is to lift the laryngoscope along the long axis. Do not tilt the laryngoscope. So not what you're seeing there, which is the picture that's marked with a big X there. because if you tilt the laryngoscope, you can't see the vocal cords anymore, and you get yourself all stressed up because you can't see the vocal cords. So if you do this correctly, this is the view that you should see the anatomy of the vocal cords, and then then it makes it much easier for you to guide the ET tube through the vocal cords. And once you've placed your ET tube, then you take out the blade while stabilizing the tube with your right hand, because you obviously check at which level you are, how deep you've put in your ET tube so that you can secure it at that level. So just to end off, post-resuscitation care is obviously also really important. You would tailor this to the level of intervention that you had to provide to the baby. You would continue to monitor the vital signs. If you need to transfer the baby, you do this in a warm transport incubator. Continue support measures if necessary during the transportation. Keep the parents informed, and this is something you can see it's written here in big capital letters. It is so logical that we should be doing this, and sometimes in this stressful situation, this gets forgotten or done very poorly. And this is really so crucial. We can, this is what the mothers and the fathers are so scared of, that something might go wrong with their babies after birth. And the very least we should do is keep them well informed. Then we need to keep the baby warm. We need to monitor the respiration, heart rate, blood pressure, and glucose. And we need to obviously document everything that we're doing in the patient file. So in summary, the golden minute, do not waste it. That is what makes it or breaks it in terms of the baby's adaptation to this big new world that is just entered. And we as health workers are in the privileged situation actually to help babies to make this transition into this new world. So thank you. That is the presentation from my side.
Thank you so much, Prof. That was so marvelous and easy to understand. And my team, I see from Helena Franz Hospital, they are watching together there. And I see we've got people from Cape Town, Mansour, Farana, I can see you. Thank you so much for joining us. Prof, thank you so much. We've got so many questions people would like to ask you, Prof. I hope you still have some time for us. But before I go to the questions, can I ask our specialist here from Polokwane, Dr. Tamiswe. Dr. Tamiswe, your comment on the presentation or the challenges you see us facing in the province when it comes to this important aspect of resuscitating the neonates.
Hi, afternoon, everyone. Thank you for the invite. The challenge that we have currently is when colleagues from obstetrics call us when the patient or the mother who has a baby that they diagnose with fetal distress, they call us the pediatrician or the pediatric team when the baby is already on the table, or when the anesthetist are doping the patient, which becomes a problem in terms of the medical officer or the registrar to attend the baby immediately, because we are working in a very hectic unit. So it would be nice if when you diagnose a fetal distress and you feel you might need a pediatric colleague, please inform us before you take the patient to theater. I usually say that once you start, the moment that you book theater or you inform theater staff, please also inform pediatric team, because you'll miss out on that golden minute. And we've been seeing a lot of cerebral palsy patients that could have been prevented. So if colleagues from the obstetric team could cooperate and work as a team, inform us so that we can be there timelessly and prepare the whole thing for effective transition to the external environment. Thank you, Dr. Mwaba.
Thank you so much. I think that is very important, because Prof has spoken about the preparation phase. Because if you come when the baby is out, when do you start finding and checking those risk factors and your preparation for the baby coming out? And I must say, Doc, it's not an isolated issue. Even in private, you find when patients are being operated, the last time they will say, oh, by the way, did you call the pediatrician? So I think it's a challenge which, Prof, I'm sure in Pretoria, it's something which is a recurring issue from your side. And do you have an advice on this, Prof?
Yeah, I couldn't agree with you more. This is so logical, and it is often forgotten. And we actually stress ourselves tremendously. You know, we could reduce everybody's adrenaline if we just prepare better. The one discussion we've had quite a few times is whether, for instance, at a cesarean section, do we need a pediatrician or a pediatric doctor at each cesarean section? And at our district hospitals, for instance, we don't also, even in a big city like ours, we also don't have enough staff to do that. And I think for routine elective cesarean sections, which are usually daytime, where there is also staff around that you can then call, it's acceptable to not have a pediatric doctor in the theatre. But having said that, you should have a midwife there, and the anaesthetist should know how to deal with that first golden minute. And if there's any additional risk factors, we should have a dedicated team for the baby ready in the theatre. And that should be non-negotiable. The other thing, and then the labor wards. I mean, sometimes we do assisted deliveries in the labor ward, and so we already know this baby is, this labor is problematic. And then we're eventually so happy to have the baby out, and then we figure out, oh gosh, but we actually don't have a team to look after the baby. And then the mother's still bleeding and all of that. So we can really anticipate a lot of these problems, and we should become much more problem-solving orientated in this regard, and not actually say that it's okay that we forgot to have a team there for the baby. It's not okay, and we should address this if it's happening at places. So there's no golden answer to this. I'm sorry, but I think we should actually say this is the expectation, and it's not negotiable.
Absolutely, no, I fully agree. I think more especially in a tertiary hospital, Prof. Most of us in Obs and Gynae, the obstetric side, we have this neonatitis, as you rightfully coined it. I think you must put this as your word, because someone is going to use it and they make money out of it. The neonatitis, yes, we have it, more especially in a tertiary institution, where you feel like once the baby is out, it's no longer your problem. You know, so where sometimes you find issue between the doctor who's doing a Caesar and the pediatrician, because you think the pediatrician must be the one on all the Caesars and all the deliveries. They must always be there because it's a tertiary institution. So it's issues which we should address as more especially as people who are leading this side from obstetric side point of view. I fully agree with you, Doc. Thank you so much. So should we go straight to the questions? Dr. Omar is asking, what is the essence of suctioning the mouth before the nose? And I must say, Prof, this sequence of saying 1 and 2, the nose has 2 opening and the mouth has 1 opening. It makes it easy to remember. And the M and N is the first time I now will actually remember exactly how it is, the sequence. So, Prof, what is the essence of starting with the mouth and not the nose?
So it is a practical one, but it is also linked to the fact that we can cause bradycardia by the suctioning, which the stimulus is more severe in the nose, so you don't want to start there. So it is both the pressure. So obviously it's actually easier to, the mouth is bigger, and that's where you start, and that's where you need to look into to see whether the babies are mouth breathers. So that's where you start, and then you move to the nose.
Okay. And Dr. Cooper from Tabazimbi, she's one of our people who are joining us every week. And thank you, Dr. Cooper. Dr. Cooper is saying, in terms of meconium, is it advisable to go straight for suctioning direct or using a laryngoscope?
Okay, so the whole issue around suctioning babies where there's meconium stained liquor has changed over the years, and we've become much more conservative with this. And this is in terms of the suctioning. So if a baby it doesn't require severe resuscitation, and if a baby is not floppy and needs positive pressure ventilation, we would actually, in most cases, defer suctioning completely. Because thin meconium in the airway is not going to cause meconium aspiration syndrome. That's the one thing. So the other thing is that the suctioning also doesn't prevent, doesn't prevent a lot of the meconium actually going into the lungs. If it's already low down in the airways, you're also not going to get it suctioned out. And what happens is you cause bradycardia by severe suctioning, and you cause, and often we waste a lot of time looking for the suction catheter and doing this and that, while we should actually be resuscitating the baby effectively. So in that regard, the suctioning the advice in meconium aspiration has certainly moved away from a big focus initially on early suctioning to actually saying we will only suction babies if we intubate them and this baby is really very flat and has is in need of severe resuscitation. But all those meconium stained like a little bit of meconium stained like, or that's we should stay away from vigorous suctioning in them. And if you do suction, then under direct vision is obviously better because you can see what you're doing.
Prof, Dr. Hamis, maybe let's go to Dr. Hamis. Dr. Hamis, I'm not sure if you are here because I see a lot of Hamises, which means some people are using your connection. If Dr. Hamis is here, about in Polokwane and Mankweng, the rounds where obs and gynae doctors would do rounds in neonates so that they can actually conscientize that doctors were doing, making those decisions of doing Caesars for fetal distress. And is it something which we can, because in other institutions it's something which is done. Dr. Hamis, do you think is something which for 2021 we should strive and make sure that that is done in even if it's a weekly basis? Is there something we could be doing on that regard, Dr. Hamis?
Okay, good afternoon again. Well, like Dr. Chamiso had already said, I think, yes, we do need to work together. Okay, first, maybe I should just appreciate that there are colleagues of mine who are in this meeting who are actually involved directly in the teaching of helping babies breathe, and colleagues also that are doing running the LINK program. They have been revitalizing the program in the province, visiting hospitals. They are finding challenges there and there when they're visiting those hospitals, but they are attending to the challenges that are at those hospitals. Coming back to the Mankweng Polokwane, I agree with you that we need to find a way of improving working together between the people in pediatrics and obstetrics. Preparation for the resuscitation area, I know there are challenges. I saw where they put that neopuff on one of the slides. There was attached to it a blender. I don't think in Mankweng, in the resuscitation in the labor room, that we have a blender. So it's either room air or a lot of oxygen that is used for resuscitation, which is not good for the babies. Thank you.
Thanks, Dr. Hamis. Thank you so much. Prof, I'll go to there's another doctor who asked, When should KMC be started in a regular breathing child with no chest indrawing or retraction?
Well, actually, immediately. You know, so KMC mean, well, if we refer to skin just after birth, we should be doing this before we even cut the cord. So once the baby is born, the baby should immediately be placed on the mother's chest and abdomen, and then covered there so that babies can stay warm. And so skin to skin and KMC, I mean, if people sometimes think about KMC more what's happening like in KMC wards, but it is this, the idea that a baby should immediately after birth be put skin to skin with the mother, which is absolutely crucial, and we should be doing that routinely. And it's because it helps with so many things. It helps with preventing hypothermia. It helps with the bonding, it helps with the milk production. And I think, you know, and even these, you know, the baby will be able to find the mother's breast and start breastfeeding. In that first hour after birth, the latching reflex is the strongest, actually. And if we miss that first hour, we almost need to teach the baby how to latch onto the breast, whereas in that first hour, it is a reflex that happens almost automatically. So the answer is as soon as possible, because it's got so many physiological effects that are important.
Thanks, Prof. So we have this for intrauterine resuscitation. Part of it, when I was still training as a obs and gynae specialist, we would give oxygen to the mother. So is there any clear studies which shows benefit or harm? Because I heard you saying that giving a neonate for the first minutes, it's better to give room air for the first resuscitation. So is there benefit or is there harm of routinely giving oxygen for intrauterine resuscitation for the mother?
That's an interesting question. I don't know. I don't know whether there are studies on that. I mean, in utero, the baby is in a relatively hypoxic environment. We need to remember that because, you know, and that's why it's got the fetal hemoglobin, so that it actually can even survive in that hypoxic environment. So I'm not sure if we increase the mother's PO2, whether how much that would actually increase the baby's PO2 in utero. I'm not sure whether anybody has studied that. But the point is then postnatally, so once the baby is born, even the 21% in room air is a complete oxygen bonanza to the baby, is much more than what he's used to in the 9 months in utero. And we could, so because of that, and because of the fact that actually it's the expansion of the lungs that is really crucial to change over the fetal circulation. And because hyperoxia in the baby, then, I mean, we can really increase that PO2 tremendously, over 100, over 200 in babies very quickly. And it is potentially harmful. And then there's the practical issues around. It's just much easier to just use a bag and mask. You don't need to connect it to any oxygen pipe or anything to start off with. So that's why we use room air for resuscitation for term babies. Yeah, both for practical reasons and for physiological ones. But I can't answer your question. I'm not sure whether there are any obstetricians on the call who have read up on that. I'm not sure.
Yeah, so I'm asking because it has been a very heated debate. I'm not sure there were studies that when you give oxygen intrauterine, and the baby is going to have that kind of environment with high oxygen, but when they get out, they won't have that. Most of the times, the challenge is that the environment will be different. As a result, the baby will now need oxygen, whereas it was not necessary. So anyone else in the audience, because all is written Hamis, so I'm not sure who should I ask, but Dr. Hamis is in the best position to tell us who could answer the question. Dr. Chamiso, do you know anything about this? or anyone from the team from Peads Limpopo?
I wanted to raise the issue about the cleaning of equipment around the resuscitation area in labor ward.
Yes.
And again, it goes back to preparing the transition. So in terms of the oxygenation, I think the less oxygen we give, the better, because oxygen, remembered, can still be toxic to the developing brain and also to the developing retina. But the main concern from colleagues on the floor is just the cleanliness of the resuscitation area. Considering that sepsis is one of the enemies in the neonatal unit, if we can just ensure that the resuscitator is clean and also the TPs or the neopath is clean for each delivery. I know it can be challenging, but if we can prioritize that, it will be very great. Thank you.
Thank you so much, Doc. So, Dr. Cooper, I know we are out of time, but Dr. Cooper is asking another question here from Tabazimbi. She's saying, is the suction device on the HBB, I presume this is helping babies to breathe, charts more effective than the suction tube we usually use?
She probably is referring to the penguin suction. That's that little mobile, that's that suction device that you actually don't need to connect to a wall suction or a mobile suction or something. I don't think it is more effective. I think it is just easier to move around and have available. Because it doesn't need any connection or anything with it. So it is ideal for labor wards that don't have wall suction readily available in all places where you have babies delivering, and that's why. So remembering HBB is really a program for low resource environments. They don't want to put in fancy things that people can't use because of the local factors. So they're trying to so I wouldn't say it's more effective. It's just easier to have available everywhere.
Thank you so much, Prof. When we have the professor in our midst, we usually expand and suck as much information as possible. We're supposed to be finished at 4, Prof, and now it's 17 past. Before we finish, I asked Prof for the last words. Just to remind you guys that on Friday is our last webinar. And on that day, we are having all the speakers, all the international speakers we have spoken, and all the speakers from our province and also from UPMRC will be there, including Prof. Bob Pattinson, Prof. Sue Focus, Prof. Mabenge, Prof. Stephen Jeffrey. They will be answering your questions. So on that day, it will be just an open session. If you want to ask these guys your questions, you will be more than welcome. And also our Honorable MEC, Popera Matuba, will be there. And you can ask her any question at all. Anything you have, no question is off limit. So you can ask on that day. So we're hoping that you will join us on Friday as well, same time. And before that, we will be having a function where Polokwane Hospital is receiving equipment which was donated by STOTS, and that function as well will be before 3 o'clock. So please join us, and it's going to be fun. Prof. Ute, it was lovely having you today. I know that on Friday you won't be available because of other commitments, but we are so excited and so happy that you joined us today. Your last word, Prof?
My last word is that we should be looking after the babies in this country because they are our future, and we should give them the best start that we can. And we are privileged as health workers to actually be there, and when they take their first breath, and we should be helping them as much as they need.
Marvelous. Thank you so much, Prof. Thank you to the Peads Limpopo team. Thank you so much for joining us. Thank you to everyone the guys from Dr. Katerisa from Cape Town, Dr. Mansour, the Dr. I see Rudani has been there as well, Dr. Omai, all of you guys, thank you so much. We'll meet on Friday. Bye-bye.